So good morning. Welcome to this discussion and on why maximizing hemodynamics should become a priority in TAVI patients. And I have the great pleasure to share this discussion with two of my very best friends, Sabine Bleiziffer from Bad Naus and in Germany, and also Vasileios Panoulas from Royal Brompton in the UK. So we're gonna go over this subject of hemodynamics improvement in TAVI patients because it may have some implications, particularly if we move to lower risk patients, younger patients with different expectations, and we will try to understand and highlight all the major points of hemodynamics improvement, definitions, how to improve, and is there a specific patient population to focus on concerning this issue. So having said that, the first question could be for you, Vasileios. We know roughly what is patient prosthesis mismatch, but if you want to put it into numbers, how do you define patient prosthesis mismatch in your practice?
So Didier, that's actually quite a tough one because we are using the indexed estimated orifice area. So we adjust it for the body surface area. And in patients that have a BMI under 30, we call it moderate if that's between 0.85 and 0.66, and severe for anyone that has an indexed estimated orifice area under 0.65. If your BMI is more or equal to 30, then moderate becomes from 0.7 to 0.56, and severe anything below 0.55 indexed estimated orifice area.
So from what I understand from your answer is that there is now a kind of update integrating the BMI of the patients in the final definition of the PPM. And this is really new, and it's going to be part of the new VALC-free definitions that are going to be available in a couple of weeks. So this was a clear answer, though. Now we know how to define PPM. The thing that we need to discuss, and maybe I'm going to ask you that, Sabine, is what is the clinical impact of a moderate or even severe PPM on the patient? What is the clinical impact?
Yes, Didier. If you have a prosthesis which is too small for the patient size, there is usually an elevated gradient. And having mismatch is in the end like having a residual stenosis. So the patient notices the symptoms of a stenosis like impaired exercise tolerance and dyspnea on exertion. In an earlier study from my Munich group, we investigated the impact of mismatch after bioprosthetic aortic valve replacement on physical capacity. And we found that patients with mismatch achieved significantly less workload on the ergometer and had significantly higher gradients, both at rest and increasing workloads of 25 to 100 watts than patients without mismatch. And also we found that comorbidities such as concomitant CABG influence the exercise capacity. So that means that mismatch is one of the factors that influences clinical outcomes. In TAVI patients, we often have multiple comorbidities that influence the clinical outcomes, and this explains why in TAVI studies on a mismatch, we often do not see a clear impact or effect of mismatch on the clinical status of the patient. So, but when we think about going to lower risk patients and younger patients, the effect of mismatch could become more significant if it remains the only factor that influences clinical outcomes.
And I liked your comparison and the fact that you said that the TAVI population so far is quite a risky population, so with a lot of comorbidities. So these patients, they are not extremely active. But if we move to younger risk patients, the findings that you had for the surgical, from the surgical literature may apply to the TAVI population. Younger patients undergoing TAVI may require larger EOAs and lower gradients, particularly during exercise. So this is very, very interesting, and this is something that I have to say we discuss more and more in daily practice. what is the final EOA and the final gradient that we're going to achieve for a particular patient. And is it something that you do also when you have a heart team discussion about the needs of the patients in terms of hemodynamics? Do you have that kind of discussion?
Sure. In our patients, the expectation of the patient always is one important point, and we will discuss later how we do our decision making on valve choice and choice of procedure.
Okay, so we come back to that later. So we've seen that there is an impact of the hemodynamics on the physical exercise tolerance of the patient. From your experience and from the literature of Vasileios, do you know what is the impact? Is there an impact on mortality, reintervention of a moderate or severe patient prosthesis mismatch?
So we do know from a big surgical study by Fallon on nearly 60,000 patients from the STS registry that showed that nearly 50% of the patients had moderate mismatch, and 10%, 11% in fact had severe. And this paper followed up these patients up to 10 years. And it did show significant differences in survival, with the ones that had no mismatch surviving about 46%, the ones with moderate to 43%, and the ones with severe down to 35%. So there was a big impact of patient prosthesis mismatch on long-term survival in that paper. The authors also recorded readmissions for heart failure, and they did show that even moderate mismatch increased the readmissions for heart failure and redo AVR as well. And we all know that redo AVR is for an elite number of patients, those who are suitable to have redo AVR. So we can suspect safely that there's a lot more structural valve degeneration going on than what is reported in the readmissions for redo AVR. And in fact, even more recently, there was a big meta-analysis of 108,000 patients from 70 studies that showed significant impact of patient prosthesis mismatch on mortality after surgical AVR, both in short term, 1 year, and up to 10 years follow-up, with hazard ratios of 1.53 for patients that had mismatch. And if we bounce that question and say, does the same thing happen in the TAVI population? We have now the study from Herman on 62,000 patients from the STS registry, TVT registry, that basically showed that severe patient prosthesis mismatch is associated with reduced survival in the long run, and even in 1 year. So we have data showing survival difference within 1 year. And I think it would be very interesting to see what happens in the long run.
So that's very interesting. So we have the data from the surgical literature, but more and more data from the TAVI literature also highlighting the impact of severe PPM on survival of the patients. And we're going to see in the future potentially structural valve deterioration also. So once again, maximizing the hemodynamics seems to play a major role, particularly if we intend to move towards lower risk and younger patients. Okay, so we need to now identify what are the patients that are higher risk of patient prosthesis mismatch. And Sabine, you did start to answer that question based on your experience, and Vasileios, you may ask afterwards. Did you identify specific patients at higher risk of patient prosthesis mismatch? Sabine?
Yes. So to make it short, these are all patients with a small aortic anatomy. So women are particularly at risk because often only a small prosthesis can be inserted. And in addition, there are the patients with very large body surface area who cannot receive a valve that is large enough for a big size patient. Patients with excessive calcium burden are also prone to maybe incomplete valve expansion during a TAVI, and that may also reduce the effective orifice area. So we also know that compared to surgical aortic valve replacement in TAVI patients in small anatomies, we have lower rates of patient prosthesis mismatch. And this is also reflected in the current guidelines, especially for severe mismatch. So what we know also from surgery is, and there is increasing evidence also for transcatheter heart valves, that there are differences in patient prosthesis mismatch incidences for different prosthesis types. So in the surgical communities, it is common sense that mismatch should be avoided, and surgical teams usually have an algorithm how to do that. And this includes first to identify the patient who is at risk by having the clinical appearance of the patient and the imaging information. So how big is the patient, how big is the valve? And next we calculate the minimal effective orifice area that is needed to avoid mismatch. And then we compare this to tables with reference data from different prosthesis types. So and then we usually choose from this table which valve could be best for the patient. So we usually plan in advance which prosthesis we would implant prior to the surgery. And if this attempted prosthesis cannot be implanted because it does not fit into the annulus, we have to do a differentiated and careful consideration if we would enlarge the annulus surgically, depending on the complexity of the surgery and on the fitness of the patient. And according to the current guidelines, we sometimes just opt for TAVI instead for surgery if there is a high risk for patient prosthesis mismatch. So with the knowledge on these different characteristics of surgical prosthesis, which are well established in the surgical community, I think we have the need for more data on this also in transcatheter heart valves. And Didier, can you comment on how the SMART trial will generate maybe important evidence in this field and what questions will it aim to answer?
So I think it's a very important point. The SMART trial, for those who are not aware of it, will be an exciting trial, very exciting trial, because it's going to randomize about 750 patients with small annuli, and that is to say a mean perimeter-derived diameter of the annulus below 23.4 or an area below 430 millimeters square. And this is going to represent, as we see usually, about 80% of a female. The beauty of this trial is that it's going to include all native anatomy, including bicuspid, but also surgical failing bioprosthesis with a labeled diameter below 23. So it's going to be a large snapshot of what we can treat in terms of small anatomy when it comes to transcatheter aortic valve implantation. And two devices are going to be utilized with a one-to-one randomization: the Evolute Pro Plus platform and the SAPIEN 3 Ultra. So the most popular devices are going to be confronted in this large head-to-head trial. The primary endpoint will be a composite of mortality, disabling stroke, and rehospitalization at 1 year. But the main focus, the main primary focus will be the hemodynamics with the bioprosthetic valve dysfunction that is going to be assessed at 1 year. Because as we saw across this wonderful discussion that we had, there may be some differences in terms of hemodynamics and patient prosthesis mismatch prevention among platforms. It's true for surgery, but it's probably true also for transcatheter aortic valve implantations. We know that self-expanding platforms seem to perform better with larger EOAs, lower gradients. But even among these subgroup of self-expanding platforms, the ones with a supraannular design perform even better. So that's why that was the background for the SMART trial. In small annuli, there is a potential for better hemodynamics, and as a consequence, in lower risk patients and so on, better exercise tolerance, better quality of life, and we're going to see probably better lower structural valve dysfunction. So it's going to be, as I said, extremely exciting. international, multicentric, randomized, everything that is needed to provide robust academic data. So having said that, I would like to thank you. It was a fantastic discussion. I was really honored to share this with both of you. And I hope that you, as the audience, you obtain enough information to improve your daily practice, identifying the patient at risk of poor hemodynamics and higher patient prosthesis mismatch, understand how to prevent it. And sometimes a surgery could be the option. If you go for TAVI, there are some platforms, particularly the self-expanding platforms, that achieve lower rate of patient prosthesis mismatch. So thank you very much, Sabine. Thank you very much, Vas.
Thank you, Didier.
I wish you all an excellent
pleasure.